it was exceptionally useful in terms of reducing these errors. And it is the basis for the timeout and a lot of the checklists that occur before procedures now to help prevent wrong site surgeries and things like this. It was partially based on the Toyota manufacturing model, the 5S, which was that things are sorted, that they are organized, maintained, that they're all perfectly aligned. You can tell that everything is correct and make sure that if anything is out of place, that you know it instantly. You're not confused by clutter. Every workstation, every operating room should be set up and maintained exactly the same way, and that you have somebody who is perpetually making sure that all of these things are the same. So every time you open the top drawer on the code cart in a rush instance, you know exactly where to grab the critical medications and tools. So this is the analogy from the automotive industry. You open this drawer, you can tell A, where everything is. If something were missing, you know what was missing, and you'd be able to much more easily function in this environment than one with clutter. So I was working with training medical residents in intubation. So unlike anesthesia, we don't have the option of canceling our cases. So we are required to be able to move forward with even critical intubations and taking over a patient's airway if they come in after a trauma, a stroke, or some other critical event. For the ability to do this, we have a cart located on the side of the room that has all the equipment that we might need for intubation. But the process when we're getting ready to perform this procedure is to go over to that cart, open up each drawer, and take out the tool that we need and bring it over to the bed. So I was training them over and over on a checklist during what's termed a deliberate practice scenario. So they have to do the exact same procedure, the exact same way every time, following the steps until they achieve mastery. And I noticed that even my senior learners would forget one or two of the pieces of equipment from that cart, bringing it over to the table out of the 22 pieces they needed. Now, if their intubation went correctly on the first try, they probably didn't need that extra piece. But if it didn't, do they have the time and ability to go back over and find the missing piece while taking their eye off a critical patient? And then I began to, so I was initially upset at them for not being able to memorize these 20 things. And then I asked myself, well, why am I making them memorize these 20 things? Couldn't I just give them the checklist? So I created this, and I can now say patent pending next to it, but it is a intubation tray. I termed it the always in reach intubation tray, air tray, and it provides a manufacturing style cutout of every piece of equipment that would be needed to provide intubation safely and effectively. It is designed to slide under the head of the mattress on the bed. All of the equipment is readily available instead of using the patient as a table, which is actually what we would primarily do because that's the space that we had available. And if you didn't have something, you would be able to quickly look down, identify the piece that you forgot to bring over from the cart, and the bottom corner has a list of doses for medications used during intubation, as well as an appropriate 70 kilogram reference dose. So if you're off by a factor of 10, you'd be able to quickly look down and realize that you made a small mistake and would be able to correct it before an error occurred. This was pioneered in the simulation center and then was able to be applied to clinical practice. So the goal with simulation is education, correct? That is why we're doing this. That's why all of us are, again, in higher education. But the goal of simulation, I'm going to argue, is not education. It is, in fact, that the goal with simulation is mastery. That we're trying to figure out a way of measuring competence, and not just that we've waited 4 years and they're fantastic and they're ready to go, but that we have a way of evaluating procedural skill and actual abilities using real data and real scenarios. So this is the difference. So do you want a surgeon who scored 95%? Well, what about an airline pilot? They're 95%, is that good enough? So that's what we're using right now as our tool to move on to the next level and on to practice. So 4 years is not necessarily the goal, but how are we taking this educational tool and using it to improve actual clinical outcomes? So the ACGME is using a set of guidelines to help us track the performance of individuals, and it's been using it for the last, I think since 2003, if I remember correctly. And it starts with professionals, and then looking at how people project themselves, whether they carry themselves in an appropriate professional manner, and they know how to do bedside evaluations using correct language, and can they interact appropriately with individuals. And how is this being assessed if it's not in a classroom setting? Is the clinic really the best place to sort of evaluate and train this, or is there a better method using standardized patients and simulation? Beyond that, we're trying to figure out ways of checking and improving patient care. So there's certain things that you can try to provide education on using textbooks. So textbook education for patient care, somebody comes in with a bee sting and you're supposed to use a blade or edge of a card to help scrape that bee stinger out. Well, that's great to read about it in a textbook. Then you have a patient who's been attacked by a swarm of bees, has several hundred stingers, and you find out that that technique is no longer applicable. So how would you be able to provide an alternative training for that to be able to apply to a clinical setting? We're working with interprofessional teams more and more. Everybody trains in their own individual schools, comes together, they meet up in the hospital, and they're expected to work together. So interprofessional education is now one of the pioneering fields with healthcare education, and one of the goals with simulation is to bring all of these pieces together. So a critical patient in the ICU may have 3, 5, 10 different teams working to help make sure that their care is set up and coordinated. And how are they getting any of that training in advance if it's not in the simulated environment? Practice-based learning. So once you're out in practice, how are you improving your clinical care? After a high-risk, either good or bad outcome case, do we take time to go back, debrief, and use simulation-based practices to improve the quality of the care that was delivered? We come out of a critical care situation like this, everybody takes off all of their equipment, they take a big sigh of relief, wipe the sweat off, and immediately move back to taking care of the patient next door without our meeting as a team and discussing what went well and what could we have improved. By getting that ingrained in the culture of medical education on the front end will allow it to perpetuate into the clinical care environment. Systems-based practice is now being considered the third pillar by the American Medical Association and being incorporated into education and training programs. But it is the idea that we are not functioning in these silos. And so how do you and your profession fit into the larger medical care group to know how to interact with and what your training as a physician means to the larger hospital systems, to the paramedics that are bringing in the patients, to the nurses and technicians in the care facilities carrying out care plans. And so remembering that you are part of this larger group and beginning to get that training ingrained earlier. Finally, medical knowledge. So we're using this in the form of multiple choice questions still because it's the most convenient way of getting large scale knowledge assessments. Gives us a convenient number, we can compare it to everybody else. But again, are we really looking at just medical knowledge, or are we looking at application of knowledge? And is there a better system to be able to manage these things? So the way that we deliver education and the way that we interact with the world changed on this date. Does anybody know what happened on this date that will forever change the way that education and life changed? Every one of us now has a device inside of our pocket that connects us instantly with the knowledge of the world. It is available to us at the bedside, it is available to us in the simulated environment. And many simulation centers frown upon the use of electronic devices and force everybody to have that knowledge memorized so that they know exactly what to do. I have changed that in our simulation center because I know that at the bedside, every single one of my residents is going to be pulling their phone out to research and look up appropriate information rather than relying on their memory, which is probably a good thing given what I've seen from many of the memories. But I want to know how they are using these tools in the training environment, because what they do in the training environment is going to translate into clinical care. Are they looking up Wikipedia, or are they looking at the emergency medicine resources that have been validated and proven? So I would encourage individuals working in the simulated environment to allow their learners to use these devices that are part of their care in the simulated environment so that they know how they're being used and actually provide that as part of their training and education. We know that they're going to be used in the classroom environment as well. So make it part of the education that they're working with. Have them have their phone out, have them researching apps, have them interacting with the lecture that you're providing. Otherwise, they're going to be checking Snapchat and Facebook. So classroom teaching has changed as well with the advent of this technology. And so how do we capitalize on it? Well, here's some of the examples. So there are social media outlets that can actually bring in novel educational pieces much faster than an advancement into journals, textbooks, or any other source. So one of these items is termed free open access medical education, or FOMED, and it is now the way that about half of the information for emergency medicine residents is initially transmitted. We need to make sure that that's tempered down, of course, because we need to make sure they have the context, because you can only cover so much medical information in 142 characters. But I've been able to provide sort of flipped classroom style training, the idea being that they get some of the information ahead of time and that we're using this training medium, that these small mobile devices, to enhance the training that they're receiving beyond what they can get out of the textbook. So it took a little bit of doing, but our healthcare institution now has allowed each department, if they wish, to have social media channels and social media access and accounts. The delivered practice sessions I was alluding to now have a video that go along with them. So every resident, as they come in, will now view an instructional video that provides the appropriate steps and expectations for each procedure they're going to be performing. They then receive a assessment and quiz based on a set of checklist guidelines for that procedure. They then go across the hall and receive one-on-one instruction with an educator who watches them perform that skill and highlights and identifies the areas that they need to improve. These set of videos are now up and available to them at the bedside because they're on YouTube and available for free, and they can go back to them both as a resident's review and in later clinical practice when they're out and realize they haven't done that procedure in 3 years. So this is an example of that virtual reality interview that I was discussing. And so has virtual reality already become ubiquitous? Well, I'm going to say no. About 1% of physicians, and I'm going to argue that they're the target demographic for most virtual reality applications, only about 1% of them have actually worn a VR headset in any real way. I'll be able to track this moving forward because my department and my chairman have actually allowed me to continue using that technique for interviewing for another few years. And so we'll be tracking to see how this technology is picked up in this group. So again, we talked about this is what the standard classroom looks like. It's just a sea of electronics and lights looking back at you. And so this is, of course, the goal as we're talking about the flipped classroom, where they're getting their education and didactics at home, and then coming in, and the classroom is the place where they can apply and practice them. Yesterday, and the reason for the late flight out over here was I was providing training for our first-year medical students in suturing. I created a set of online lectures now for them that they have access to. They have a procedural video just like what was demonstrated, and they can now see those items in advance. It saves 4 hours of classroom time. They come in, they are able to demonstrate and receive one-on-one instruction from a group of educators on both pig's feet and silicone suture pads. They then get up and move on to their next session, and the educators are no longer having to repeat the same lectures over and over again. And it improves the efficiency of classroom utilization as well as the time and utility of the educators involved. We now have the ability to share videos electronically. My current presentation is being recorded, so it can be reviewed later. This can be done either real time or delayed, but we now have the ability to share live streaming of any type of educational activity. I think just about every phone being produced now, the smartphones in the last 3 years, has built in, whether people knew it or not, the ability to live stream using the video camera straight to YouTube and a live presentation to the world. So all of your lectures and presentations could be put out for real-time interaction using social media channels and getting that feedback and interaction from your learners. I tried to push this out to the emergency medicine community and put a list together of the nearly 200 emergency medicine residency programs that are all required to do the same lectures and didactic presentations every year for their group of 12 to 20 learners. And if we could get one site that was willing to do that lecture that week, you would take the number of people having to repeat the exact same mediocre lecture and have one expert deliver it once per year and share it with all the other groups. You would decrease the amount of time there and allow people to focus on research, innovation, and clinical care. So this particular demonstration shot here was from an advanced hazmat life support course that we offered at our training center. And this video was able to be shared with an expert toxicologist out of France. And he was able to interact with those learners in the room and provide feedback on their care. So in 2015, there was a report about higher education and advancements in classroom technologies. And they thought in the next year, this was again 2 years ago in 2015, that the bring your own device and flipped classroom models would become highly accessible and an expectation at most centers. And I think most people are aware of these activities. The bring your own device, whether we wanted that or not, is happening. And then figuring out how to use those devices into your classroom curriculum is obviously harder to integrate with fixed curriculums, but it's something that we can start looking into. Over the next 2 to 3 years, which we're starting to be in the timeline now, they were looking at maker spaces and the ability to have fabrication labs and innovative building locations on technical campuses, and even in smaller areas with the cost of 3D printers for home use coming down to be well under $1,000 and several under $500, making them almost a necessity at any small, even high school or college campus. And then, of course, wearable technology. The use of this, particularly for education, I'm still questioning, but it has been used effectively in the healthcare field. The patient came into the emergency department in a recent case report write-up and had developed palpitations. They were shown to have atrial fibrillation on the monitor, and the treatment for this could be immediate assistance with cardioversion, but they couldn't tell whether it had been present for a while, and if it's been present for more than 72 hours, the risk of a clot forming, converting to a normal rhythm, and pushing that clot out into the brain and causing a stroke is much higher. The patient happened to be wearing a Fitbit. They were able to look back and found 12 hours ago heart rate went from 60 up to 180, and they knew exactly when the onset had occurred and were able to provide appropriate intervention right on the spot. So we're moving towards adaptive learning technologies and the Internet of Things. I was talking with a gentleman back in the room that had just attended a conference this past week looking at where the Internet of Things is going and what it might be able to provide in terms of innovation. And that's one of the places that we're probably going in the near future. Adaptive learning technology is the idea that testing is no longer just a raw score. It's that as you take tests and as you answer questions, that they may become either progressively harder, progressively easier, or help guide you to be adaptive to the areas that you need to focus on. So this is no longer just a paper multiple choice test, but one that changes depending on how you answer previous questions. So this was the report that was put out in 2017 from that same group, and it listed that they kind of pushed towards some of these same things, but the adaptive learning technologies and mobile learning, where people are going to be able to carry their individual testing and educational platforms with them outside of the classroom and into clinical environments, decreasing the need for fixed classroom space. We're also going to be able to move towards next generation learning management systems. This is going to be where you have a better way of sort of organizing classroom curriculums and the way that the students interact with them. Probably a bit off in the future, although they gave it a 4 to 5 year timeline, is going to be the idea of artificial intelligence and natural user interfaces. We're already getting a glimpse of this if any of you have either a Google Home or an Amazon Alexa in your house. Not quite full artificial intelligence, but it is able to, with fairly good utility, interact with natural voice and speech. so that you can ask questions, get responses back. And one of the simulation companies has actually partnered with the Alexa, Amazon kind of voice application into their mannequin, so that you are able to begin asking questions in a natural voice and manner and get real-time responses programmed in, potentially even across multiple languages in the very near future. So this is being pioneered already and is going to find its way into the simulation space in the not too distant future. So there's the constant reminder that technology is not infallible and that there are technology-induced errors. So electronic health records were designed, and many of them are still on the same design from when they first came off, because it's pretty hard to change a giant product like this off of technology from 10 or even 15 years ago. And the natural user interface and design may not have been adapted or updated to meet the needs of the current clinical educators or practicing clinicians, sorry. So figuring out ways of potentially bringing these electronic health records into a simulated environment, or having somebody really track and follow how they're being used to help improve them may be important. They found that many of the health records may sort of obfuscate information and put it in a location that's either not convenient for those interacting. An example, in our own hospital, just recently they moved to a new point-of-care urine analysis, which was fantastic. Instead of having to collect the urine, send it across to the lab, wait for it to get batched, have the sample run and report it back to the computer, which took upwards of an hour and a half, which is still fairly quick, but when you're trying to have turnaround times under 4 hours, adds every little bit of time. They managed to get point-of-care testing where they were able to do dips right at the bedside and enter the information into the computer system in 10 minutes or less, which is fantastic, except they didn't put it in the same tab as any of the other laboratory information. It was buried 3 levels down into a text box that had to be sought out and clicked. And by the time you realized it was there, it was at least as long as waiting for the lab to put it into the usual format. So we can work on improving these electronic health records in simulation if we are able to partner with the companies and the clinicians to have them come over to a learning environment where they can be used. One example of this was a company that had created a user interface layout that put on top of existing electronic health records. Unfortunately, the company has now folded, as I understand, but it was called Sparrow EDIS, or Emergency Department Information Systems. And it took the standard electronic health record information, which was in the healthcare record 7 format, which is just a database of name, it goes in this field, and date of birth goes in this field, and put it into a natural iPad user interface, which was much more user-friendly and efficient. And it fit on top of an existing health record. So somebody wouldn't have to get rid of their Cerner, wouldn't have to get rid of their Epic, but would actually have a well-designed user interface that worked with it and was customizable to meet their needs. I ran residents through in a randomized controlled trial where they were given a video presentation of an encounter with what I consider to be 3 classic presentations. So we had a chest pain patient who ended up having a slight, a nondescript troponin elevation and required inpatient management. A patient needed to be admitted to surgery for a cholecystitis, and then a depressed patient who was being evaluated for a Tylenol overdose. And they were given a video demonstration of each of these and timed based on their interaction with them to see how much time it took for them to put in orders, write notes using this system, as well as our existing electronic health record. And we found that even with no training, that the time it took for the individuals typing into this new well-designed system was actually close to equivalent to a novice user of our existing health record. Now with training, both systems, with training, the existing system was actually faster for our advanced learners, which would make sense, knowing that advanced training does make you faster at order entry. But it would allow you to focus your clinical care time and training on how to use and interact with the healthcare record, because that ends up being the majority of clinical time for most practitioners in terms of an efficiency standpoint. But pulling that activity into the simulation center can allow for a specialized education where you don't have time to do it in clinical practice. So the training is going to happen regardless of what's going on, and you need to figure out how to design it to meet your needs. So it's coming back again, starting with what your goal with training is and making sure that you are designing it to match that. Simulation is not going to go away, and in fact it may get bigger. So this is a congressional bill that is being put forward now that would change and remove all animal-based training for the military and require simulation-based training for all healthcare education within the military. I have not had a chance to check in the last couple of months to know whether it's making any progress. I understand that not much of anything is making progress right now in DC, but we will see where this goes. It would certainly change the way that simulation is consumed by the military and the requirements for its infrastructure and support. So there have been a couple of studies looking at augmented reality and some of these technologies, and of course people have found that they, in their specialized subsection of their research, are able to make improvements. Now this is going to be very easy to accomplish, but it requires that you know how the technology works and how to use it. This does not mean that every time you use augmented reality you're going to get better learning and better outcomes. It's how you apply the technology and making sure that it meets a specific need that you have at your program. This was a grant-funded project that is free and open, and I actually hope you would write it down. I have no affiliation with them, but was amazed at what they were able to do so far with it, and is an example of augmented reality. These QR codes that you see up here function as keys to clinical simulation environments and to scenario progression. The idea is the learner would interact using an iPad, walk into the room, and ask the patient how they're doing. They hold the iPad up, the iPad recognizes that QR code, and will then play a video file of the patient having an asthma attack and having trouble breathing. They would then say that they needed to provide albuterol, and you would go over to the medicine drawer and scan the QR code on the albuterol, and the albuterol would be administered. The entire case is designed to be progressed through using these QR codes as triggers to advance and provide user learning and feedback on what they're doing. Their goal with this project when they presented it at the conference in July was that they would have 50 complete cases ready to use using this, and it was going to be an open access program because of the grant. So all of these technologies are being used around the world, and they are impacting healthcare education both here and internationally. There have been studies looking at the mobile learning platforms and making mobile education available. The WHO has found that there would be shortages based on provider training and availability, and they are looking at mobile training platforms to help provide improved education, especially in third world countries, to make sure that learning and education is available to those developing areas, and provide adaptive technologies to help those already in practice or just starting again to improve their clinical training. So that's getting basically to the end. I have a few quick little demonstrations. There was a lot covered in that. Are there any questions from the group I can try to help address if anybody had anything specific?
I just hope that it clarifies for everyone the actual scope of what the graduates from this program are going to have to deal with. Everything that he's brought up here, everything he's demonstrated today, is going to be the world that our graduates live in. They're going to be, it's a constant changing, ever-evolving environment, and ever-expanding technologies, and they're going to have to interact with the doctors and the nurses and the physicians that are trying to teach these things and script these scenarios. And they're going to be living in that world doing that. And I hope that it's kind of a daunting task, and it's really an opportunity that is just really unbelievable, because it's going to explode. I mean, there's just no other way around it. Learning has changed. Do you have anything else to add on that?
I mean, just from what I've already seen in the time I've been trying to improve the scenarios in education that I myself am working on, every time I attend a conference, every time I go and speak, I am learning so much more about what is available and how to bring back tools to aid in the education that I'm providing.
I just have a quick question. I've used QR codes before in our instructional department with our Sendapper.
Okay.
But something I've been looking at, and you have such a great look at innovations, but I'm using the LifePrint.
Which one?
It's a LifePrint software, and it's, I was just wondering, it's a object identification software.
Okay.
And I was wondering, because they're using the QR codes, but it's just so static. But with the object identification software, and if you can get it small enough, you can actually just come over with your smartphone, and it actually plays the entire video and everything without a QR code. Is anybody, I was just thinking, that's a great innovation. Has anybody done that yet? Because it's something I...
So was anybody able to download the app that I mentioned at the beginning? So if you aim your phone at the screen up here, you might actually be able to get this to work, I hope. If not, I'll move on to the next slide, which will hopefully play. This, unfortunately, was designed to be sitting on a table, so the image will look a little bit strange to you being projected on a screen like this. But I worked with a software developer and programmer and computer graphic artist out of El Paso, who used to work for Raytheon and is now working as an artist doing community augmentation of existing artworks and murals. So again, the idea with augmented reality is that, I'll step out of the way so everybody hopefully get a clear view of the screen up there. So augmented reality, again, is the ability to project computer-generated images on top of existing structures. And so with this, imagine that this is sitting out on a table as part of a classroom learning exercise. What you're seeing on the screen in front of you is a three-dimensional heart being projected up right in front of you, and on the side there's an option that says interact or labels or something like that, and it will send in the labels for the locations on the heart with each of the anatomical locations. You can also rotate and spin the heart in real time, and if you wanted, you can actually get up and walk around the room and you will be able to see different angles of the heart as you move around. The only trick is you have to keep some portion of the image in the frame on your screen to keep the augmented reality picture present.
That's cool.
So this is one application for where augmented reality can help enhance existing either simulation or classroom learning. But also picture now what it would be like to have the Harry Potter newspaper, where as you're reading, you actually have a video start to play back at you. Now, this will have some audio with it if you have, which will be a little odd as everybody's phones start going off. But as you're reading through a textbook chapter now on what it's like to place a chest tube, you will now receive a video demonstration guiding you through the procedure with interaction. Is it working for everybody, I hope? It may take a minute to download it. It's pulling it from the server, so it keeps the program a little bit smaller.
How small can the target be for this?
Say again?
How small can the target for the recognition be for this?
So the target can be any size you want. It just has to have enough resolution that the target, so again, this is basically turning every picture, regardless of how integrated it is, into a barcode with at least 3 points that are recognizable because it defines the plane that the image is being projected onto. Set over this. As you're working with your action design, you can create any size, as long as the camera can recognize it.
That's the problem with
I think we're working on that.
Thank you. This is
It's actually an application called Erasmus. Have you heard of that one? It does a similar thing. You put your phone over the image and it plays a video or audio or something. It's similar. We have it on our website. None of us have used it yet. But just we found it. Haven't been able to really put it into force yet. It does similar things.
That's the kind of thing that will pull into some of these innovative educational components. But again, you have to know what exists and then figure out how it matches with the educational need of whatever curriculum you're working with. Here's one more just to play with if you want. The idea with this is you can take that CT or MRI data from a real CT scan and then break it apart so that it becomes a functional piece. Not quite sure what this one will look like for you. It usually is zoomed out fairly high out on the image, so it could be a little awkward for you depending on how far back you are. Now, it should show a three-dimensional brain, and if you touch on pieces of it, they will highlight in colors. And if you click on the little button on the side that says interact or exploded view or something like that, it will take the components and not quite anatomically correct because it was just done for demonstration, but we'll separate everything out so you can see and interact with it a little bit differently. These three pieces were done actually just for free as a demonstration of the technology. It's going to be part of a discussion in a textbook I'm working on simulation operations and educational innovation.
Wow. The exploded view is awesome.
That's awesome. Wow.
That's really cool.
Doctor, so this style that you're talking about, where basically you look at something at home and then go in and do the simulation. Could you see that this would actually speed up the amount of time it takes to do medical intervention?
Absolutely. I
So
mean, you can.
people wouldn't have to invest as many years, perhaps?
Well, so you have to be careful with that, but the way that the years are invested could be different. But certainly, I mean, right now, one of the tricks we have in emergency medicine is we have moved to this competency-based system. That's the goal with education where it's going right now. And so right now, I meet with a clinical competency curriculum group, so the primary educators within our residency program, and we come together and we rate the residents in each of 21 separate skills. Using data from clinical practice, using data that we observe from simulation, using data from textbook knowledge tests. And the goal is to get everybody up to a level 4 for graduation. Now the problem is if I have an intern that is already a level 4 in every category, no, I can't actually let them go early. So why are we doing this? And that's one of the questions is when are we going to get to the point that as a educational community we're willing to accept competency as a means to early graduation, because we are still fixed in a 4-year system, partially because it's based on the economic model that allows and requires it to function in that way. But that's one of the places that will need to be addressed as we get to a better means of assessing clinical competency earlier. But that also means on the corollary, we have to be able to provide for learners that aren't ready at 3 and 4 years, and what do we do to retain them, and who is responsible for any additional costs there. So the financial component will, of course, be a large discussion with any of these competency-based learning.
Could you just briefly give a synopsis on how a simulation technical specialist growing up in this world and coming out and getting their feet wet from this program and going out is going to use all of this, integrate all of this interdisciplinarily, for scripting and staging and programming and running and documenting? How are they going to be able to tie all that together?
Okay. So right now, there are a couple of different groups that have looked at the required knowledge base for the simulation technician, the simulation operations specialist. And there are components that they need to have expertise in, from information technology, and how to get all the mannequins and educational tools to talk together, since they're set up on networks and use servers for all of the learning management systems, the IP-based phones, the networking equipment that communicates with the video cameras, and how all of that works together to help the educator with evaluation and debriefing during a simulation. There is a component of audio and video engineering requirements to know how to use and troubleshoot microphones and audio systems as you provide an immersive learning environment, both through overhead PA system paging to keep everybody on track for organization, versus playing the part of the mannequin in a semi-hybrid or standardization format. Many programs are starting to utilize voice modulating and voice changing technology, so the operator behind the screen can have their voice sound like a male or female patient, or have a waiver so they sound like a geriatric patient, to help engage and pull the learners in. And so having a background in knowledge in that and knowing how it can be applied, or whether it needs to be applied for the type of learner that they're working with. Appropriately being able to take clinical and medical knowledge from taking a script that has been produced by the educator and being able to create an immersive learning environment that matches with it. So when they say that the learning objectives for this case is going to be evaluating emergency airway control, providing intubation, and appropriate ventilatory management, that's a great case and a great set of learning objectives. But the person who's even setting up, maintaining, and reading it needs to know how to intubate a patient, probably using at least the simulated version, so that they can have an airway placed in advance. They need to know what the ventilator is and how to set it up so that it can interact with the mannequin, and know how all of the tools that are used function so that they're ready and working when the learners get into the room and start to try to interact with them. So that's one other set. They also need to know about the educational ideas, and at least the educational theory, and why it is that we have learning that occurs in a hands-on immersive environment as opposed to just textbook learning, and understand the concepts going along with debriefing and the need for creation and maintenance of a safe learning environment for all of these things to transpire, so that they understand that it's important and allowed for learners to make mistakes in this environment, to be able to translate that into safer clinical practice later, and to be able to support all of these activities so that they start to form this larger simulation picture. But then, of course, knowing how each individual piece of simulation equipment in their center works and interacts will allow them to talk with the educator, pilot educational curriculum, pilot new simulation scenarios, and appropriately design them so that they can be much more immersive. And again, rather than just having that mannequin out on the table and adjusting some vital signs on a screen, that almost makes it into more of a tabletop exercise. But having an irate family member come into the room at the appropriate moment while they're trying to deal with a critical procedure and figuring out how to appropriately interact and calm them down, or know what resources they can call to come into the room to help support them. It's no longer just the knowledge base. We can do that at multiple choice testing, but it's integration of that knowledge into a specific clinical environment and calling into question some of their expectations by challenging specific things that they have been told that might be always true, except when. And that's where the beauty of simulation is. You can define and build a scenario to exactly meet that except when that you will only see once in your career, but if you don't train for it in advance, you're going to be hard-pressed to come up with the correct response when it does occur. So having that knowledge of all of these pieces together to work with the educators is going to be what creates the functional educational environment.
Great.
Doctor, I got one question.
Yeah.
Kind of a chicken and egg question. I'm interested in your background because you started with technology and then acquired medical skills. Is the reverse also applicable? Can you start with medical skills and then graft on the technology skills, or what do you think works best?
So I've been asked that question many, many times. So everybody's saying, oh, well, I need a new sim tech in my center. I need a new operations person. So do I hire an educator and teach them about some of this audio video stuff, or do I pull the IT guy over and then put him through an ACLS course? You know, what do I need to do? And the answer is, it depends, of course. It really matters what your goal is with the center and what your goal is with the education and what your specific deficiency is. A lot of programs aren't large enough to have more than maybe 1 or 2 or 3 personnel total for a center, and that has to encompass all of those roles of educator, administrative coordinator, and technical specialist. It may not be cost effective for those small centers to have that technical specialist with an engineering background that's going to be pioneering and innovating. But it may be important for them to have enough of an IT background that they can set up and operate the equipment to work with the existing pieces that you have. Now, the vendors for these large products are of course going to provide support, and there's no reason not to take advantage of those when needed. But if you can have the resources in-house for certain pieces, you can decrease the financial resources that you might need to import. And so that kind of is where you would want to address how to go about this. But if you have enough educators, or you have somebody who's able to provide education already, whether they're involved with simulation or not, you're pulling a practicing clinical nurse or physician over from a hospital to help with the educational component, then having somebody with a more technical background to work with them and help support them might make more sense. But obviously, you have to start with somebody with an educational and clinical background to provide that information. Once you have that individual, even if they've been imported, you need to provide the technical expertise to support and maintain the equipment. But that may require a simulation-specific knowledge base that basically, unless they're going to be coming out of this program, doesn't exist yet, unless they've already been working in the field somewhere else, but they've just acquired it on the job at that point.
So it might be, you have, I have a lot of IT technicians that report to me, and they're like, hey, come make this thing work. I don't know, what is this thing? How does this fit into the team effort? So it might be better to have the medical team and then have this person as a team member.
Right, so initially you might need 2 people going together, one with the IT knowledge and one with the simulation knowledge. But the goal is that you want to find somebody who is interested and eager to find out, the tinkerer who wants to know how and why things work. That's the person who's going to be able to acquire and train into the knowledge to meet this need. But there's been some suggestion that finding people with sort of at least an engineering interest or engineering mindset are going to be able to look at something and figure out how and why it works so that they can learn how to make it continue to work inside of the larger system. But those that are kind of fixed and rigid in terms of function aren't going to be building and expanding upon the existing technology, even if it's just how to bring 2 or 3 pieces of existing simulation equipment into function in a single case.
Thank you.
And I'm happy to just wander around without the microphone and chat and answer questions if anybody wants. So.
I thank you for coming. I really appreciate everyone that came out. I wanted everyone to see from this just how dynamic this industry really is. I've been telling people it's hard to find accurate textbooks for this because as soon as they're printed, they're obsolete. And it's the toolbox that our graduates are going to have is more than one trade. They're going to have to carry a whole backpack. And that's been the skill in sculpting this program and trying to work with it. Dr. Farias over here and Pam and Sarah, all the rest of us trying to make this happen. You've given a good example that we've only seen the tip of the iceberg. This is just the beginning. And with what we're doing with this program is we are getting them essentially ready to simply begin because this is where they're going. And I really appreciate you coming out and doing it.
I'd like to thank everybody in this room for coming out and for giving me the opportunity to come and speak with you. I'm hopefully obviously passionate about this and very interested in making sure that simulation and healthcare education are being taken where they can and should be going.